Yep, looks great.
All right. So we are 6 days away from the residents starting. It seemed like a lifetime ago I got hired on to start this initiative, and I'm very excited to see that they're finally coming. So instead of esoteric conversations like we've had with some of our other faculty development sessions, this is going to be what to expect when you're expecting residents. As always, I have no disclosures, and our objectives here are just to get us ready for the residents coming. So a couple of reminders. These are all physicians, all right? So they've, most of them have graduated medical school this year, and this will be their first clinical experience. Two of our residents have internships behind them. One is just finishing a surgical internship. The other one did her rotating osteopathic internship and has been a battalion surgeon for the Marines for the last 4 years. So they're all coming in with different backgrounds, but they are all physicians, and they all need physician supervision. So what does that mean? As PGY1s, which is what they're going to be required. Oh, I don't know why we're talking over that. But PGY1s require indirect supervision for the evaluation and management of a patient, meaning that your intern is going to be able to go and evaluate the patient they sign up for, come back and put in orders, do their initial history and physical examination. And when the stuff starts coming back, they're able to make those interpretations and make changes to the plan as according. During some of that time, though, they have to come to you and present the case, and every one of us is going to have to make that determination of how much we want the resident to do before presenting. And this is for the run-of-the-mill patient. They require direct supervision when they're managing critically ill patients. So for a patient that comes into one of the resus bays, somebody that's code blue, somebody with unstable vital signs. This is not something to just send the resident in and figure some stuff out before you pop in. You go in with them. Ideally, let the resident try to formulate some ideas, get some of the management. But if the patient's crashing and the resident's not acting fast enough, which as a PGY1 they may not, it's okay for you to take over care, for you to help direct care more aggressively than you would say for a sprained ankle or run-of-the-mill COPD exacerbation or an pneumonia case. But if the patient's unstable, you need to be there. The other thing you need to be there for are for procedures. So specifically, if they're putting in a central line, if they're doing a chest tube, if they're intubating. Again, a lot of those patients are going to be unstable, so you're going to be in there anyway. But for even suturing the first time or until they're comfortable doing it, doing an IND, all of these procedures, you need to make sure that you're there and overviewing what the resident's doing. So there's a resident column coming on FirstNet, and this should be released on the 28th of this month. So if you look over to where we click on the chart now, in the doctor column, there's going to be a new column for the resident. Now, my understanding is when the resident clicks on it, it should not fall off the my patients and unassigned patients, because that's going to be defined by who clicks on the doctor column. And again, they're all physicians. We know that they're doctors, but this is the way that our FirstNet was built. Attendings are doctors, residents are residents. So make sure that any case that the resident is seeing with you, not only have they signed up, but you've signed up as well. Now, at the bottom of the chart, after the disposition blurb, there's the little addendum that probably most of us are using right now for the APPs. But there's also a teaching supervising addendum there too. So these are the things that must be clicked. You participate in the patient's care for the history, physical, and MDM, and supervise the care, history, exam, and MDM of that resident. You discuss the case with the resident. If they did any procedures, you'd click that procedure box, as well as what procedures you did, and if it's not listed, you can click other and text box it. Agree with what they did, unless you don't. And we'll talk about that in a second. So if you don't, so if you've read through the chart and resident says patient sprained the left ankle and gives an example and describes what's there in the left ankle, but it was actually the right ankle, then you, instead of blocking out agree with, you'd unclick that and instead click this agree with exception, and this will pop up. And in this area, type what you disagree with. So patient didn't sprain right ankle, patient or left ankles, patient sprained right ankle. Patient had superficial and partial superficial burns on 20% of the body, not 12% of the body. Whatever it is, put here. And I actually had a meeting with Envision Legal, and talked about this and verified. You do not go back and change the text. And the reason for that is, again, they're physicians and they have typed something into the legal document known as the chart. So you don't want to go back and change what they wrote. This is your opportunity to make the change. And one of the questions that always comes up is, doesn't that put us more at a risk from a legal standpoint? And legal assures me that it doesn't. In fact, it shows that you did what you were supposed to do, kind of check the resident's work, and you've reviewed their chart so diligently that you know what's not correct in the chart, and you've made the change. So please do not go back. If you go back and change the data, it's still in the metadata, which can be pulled by counsel, and that looks worse, having messed with the metadata. This is your area to make the change. Now, if the resident hasn't signed the chart,
yes. I was going to ask, can you not ask the resident to make a change if it's something ridiculous that they have written?
I was just getting to that. If they haven't signed the chart yet, they can go back and change it. And if you haven't signed the chart yet, you can ask them to go back and change it. But if everything's signed, and we should be seeing these sooner than some of the floor docs will. These should kind of be done just as we do our own charting before the end of the shift. But if you can do it at that time and have them change what needs to be changed, absolutely do that. But if something has to be altered after the resident is signed and sent it to you, agree with exception and go ahead and make the change in this box. So I'll pause here to see if there's any questions about resident charting.
Question.
Yes.
They've been instructed on certain things that you never put in the medical record. Hopefully they have, because they've been doing this now for a little while, I guess. But because you know what I'm saying. I mean, it'd be like somebody in triage says this child is lethargic, and they put them on the back burner, right? And we're all on the hook because now, if somebody's documented that, we have to make sure this kid is not lethargic, or if they are, they need to go straight back. Just in terms of any jargon that is really going to put us out on the spot, have they been taught, or?
They will be. They have a introduction, or we have a whole series of introduction lectures coming up next week with the residents and the week after. And we have a whole section on charting.
Excellent. Thank you.
You're welcome.